Primary Sjögren syndrome. Primary Sjögren syndrome is characterized by lymphocytic infiltration of salivary and lacrimal glands, leading to glandular fibrosis and exocrine failure. The typical age of onset is between 40 and 50, with a 9:1 female to male ratio. The disease may occur with other autoimmune diseases, that is secondary Sjögren syndrome. Now, the clinical features. The eye symptoms termed keratoconjunctivitis sicca are due to a lack of lubricating tears, which reflects inflammatory infiltration of the lacrimal glands. Conjunctivitis and blepharitis are frequent and may lead to filamentary keratitis due to binding of tenacious mucous filaments to the cornea and conjunctiva. Oral involvement manifests as a dry mouth, xerostomia. There is a high incidence of dental caries and high risk of dental failure. Other sites of extraglandular involvement are listed in box 2464. Often the most disabling symptom is fatigue. There may be an association with inflammatory small joint osteoarthritis. Clinical suspicion, though formal studies have not been done. Sialadenitis, osteoarthritis, and xerostomia syndrome has been described. This may occur independently of PSS, primary Sjögren syndrome, or more likely constitute a mild form. Both interstitial lung disease and interstitial nephritis, sometimes complicated by renal tubular acidosis, require proactive screening. Primary Sjögren syndrome is associated with a 40-fold increased lifetime risk of lymphoma, though the complication is still very rare. Now, investigations. The diagnosis can be established by the Schirmer tear test, which measures tear flow over 5 minutes using absorbent paper strips placed on the lower eyelid. A normal result is more than 6 mm of wetting. Staining with rose bangle may show punctate epithelial abnormalities over the area not covered by the open eyelid. If the diagnosis remains in doubt, it can be confirmed by demonstrating focal lymphocyte infiltrate in a minor salivary gland biopsy. Most patients have an elevated ESR and hypergammaglobulinemia and one or more autoantibodies, including ANA and RF. ANA negative disease exists. Anti-Rho and anti-La antibodies are commonly present. Patients with joint pain, fatigue, and rheumatoid factor with or without ANA need careful assessment because a number of possibilities exist. Primary Sjögren syndrome and inflammatory osteoarthritis, rheumatoid arthritis with incidental ANA, rheumatoid arthritis SLE overlap, or rheumatoid arthritis primary Sjögren syndrome overlap. Knowing ACPA status can help if it is positive in rheumatoid arthritis. Interstitial lung disease complicates primary Sjögren syndrome in a sizable minority of patients. Persistent dry cough, dyspnea, coarse velcro crackles on lung auscultation. A chest X-ray and lung function test should be performed. Now, features of primary Sjögren syndrome. Risk factors includes age of onset 40 to 60, female is more than male, HLA-B8, DR3 positive. Common clinical features: keratoconjunctivitis sicca, xerostomia, salivary gland enlargement, rashes, skin irritation, non-erosive arthralgia, generalized osteoarthritis, Raynaud's phenomenon, fatigue. Less common features includes low-grade fever, interstitial lung disease, anemia, leukopenia, thrombocytopenia, cryoglobulinemia, vasculitis, peripheral neuropathy, lymphadenopathy, lymphoreticular lymphoma, glomerulonephritis, interstitial nephritis, renal tubular acidosis, Autoantibodies frequently detected rheumatoid factor anti-nuclear antibody SSA, that is anti-Rho, SSB, that is anti-La, gastric parietal cell, thyroid. Associated autoimmune disorders: systemic lupus erythematosus, systemic sclerosis, celiac disease, primary biliary cholangitis, chronic active hepatitis, myasthenia gravis. Now, the management. No treatments that have disease-modifying effects have yet been identified, and management is symptomatic. Lacrimal substitutes such as hypromellose should be used during the day in combination with more viscous lubricating application at night. Soft contact lenses can be useful for corneal protection in patients with inflammatory keratitis, and occlusion of the lacrimal ducts is occasionally needed. Artificial saliva sprays, saliva-stimulating tablets, and pastilles and oral gels can be tried for xerostomia, but often chewing gum is most effective. Adequate postprandial oral hygiene and prompt treatment of oral candidiasis are essential. Vaginal dryness is treated with lubricants. A trial of systemic pilocarpine 5 to 30 mg daily in divided doses is worthwhile in early disease to amplify glandular function. Hydroxychloroquine 200 mg twice daily is often used to address skin and musculoskeletal features and may help fatigue. Immunosuppression does not improve Zika symptoms but is essential for progressive interstitial lung disease, example glucocorticoids and cyclophosphamide, and for interstitial nephritis if hydroxychloroquine is ineffective alone. If non-resolving lymphadenopathy or salivary gland enlargement develops, biopsy should be undertaken to exclude malignancy. This figure shows typical eyelid appearance in dermatomyositis. Note the edema and telangiectasia.